I'm Dr. Lauren Gerson, an Associate Professor of Gastroenterology at Stanford University. I'll be discussing a manuscript entitled Impact of Inpatient Status and Gender on Small-Bowel Capsule Endoscopy Findings that will be published in Gastrointestinal Endoscopy in November 2011. My co-authors on this manuscript were Carl Robinson and David Condon from Loma Linda University, Christian Jackson from the Loma Linda VA Medical Center. Video capsule endoscopy is recommended as a third diagnostic test in patients with obscure, overt, or occult gastrointestinal hemorrhage after a normal upper and lower endoscopic examination. It has been published that capsule endoscopy has a higher diagnostic yield when performed within approximately 2 weeks of an overt bleeding episode. It is not known, however, if performing this examination when patients are hospitalized is associated with a higher diagnostic yield compared to performing the examination as an outpatient. The aims of the study, therefore, were to determine the yield of inpatient video capsule examinations compared to a cohort of patients undergoing outpatient capsule, and to determine the effect of gender on diagnostic findings. We performed a retrospective study between 2005 and 2009 and enrolled patients who presented with overt or occult gastrointestinal hemorrhage. All patients received preparation prior to capsule with a liquid diet and 2 liters of Go Lightly. We collected data from the capsules, including patient age, gender, inpatient status, transit times of the capsule through the stomach and small intestine, preparation quality, findings graded on the P0 to P2 scoring system, where P2 represents a highly significant finding and P0 normal examination. And for inpatients, we collected information regarding presence of comorbid conditions. The limitations of this study were that we were unable to determine exactly timing between the last episode of overt bleeding and the capsule study. We were unable to collect information regarding comorbid conditions for outpatient capsule examinations. It was a retrospective study. We did not have information regarding usage of aspirin, non-steroidal anti-inflammatory agents, anticoagulants, clopidogrel, or other medications that may have affected bleeding or results of the study. And we did not have a standardized grading system to rate the quality of the preparation of the capsule exams. Our results are that we studied 707 capsule endoscopy examinations, 167 performed on inpatients, and 540 on outpatients. As shown in the table, there's no significant difference between the mean ages of the inpatients or outpatients. There were, however, a significantly higher proportion of patients who were male inpatients compared to outpatients. Approximately 73% of the inpatients were males compared to 61% of the outpatients, and this is statistically significant with a p-value of 0.004. There was no significant difference in the number of veterans who were inpatients or outpatients. However, inpatients were more likely to present with overt GI bleeding, which is present in 83% compared to 46% of the outpatients. The gastric transit times of the capsules was significantly longer for inpatients, with a mean of 56 minutes compared to 38 minutes for outpatients. In addition, the gastric retention rates were significantly higher in inpatients, occurring in 7% of the inpatient examinations compared to 1% of the outpatient studies. However, there was no significant difference in the small bowel transit time. There was, however, a significantly higher proportion of inpatients who had incomplete capsule studies to the cecum. This occurred in 30% of the inpatient examinations compared to 19% of the outpatients. Overall, inpatient capsule examinations had a higher yield of significant P2 findings, occurring in 49% compared to 37% of the outpatients. And in addition, inpatients were more likely to have significant findings outside of the small bowel compared to outpatient studies. When we looked afterwards at gender analysis, there were 454 males and 253 females. There was no significant difference in the mean age between men and women or in patients presenting with overt GI bleeding. However, males were more likely to be inpatients at the time of their capsule examination, They represented 28% of inpatient examinations, compared to females who represented 18%, with a p-value of 0.005. In addition, males were much more likely to have significant findings on capsule, occurring in 44% compared to 32% of examinations. And males were more commonly found to have angiodysplastic lesions on capsule endoscopy compared to females. And again, this is statistically significant. There were no other significant differences for other findings, including ulcerations, strictures, neoplasms, and other findings. However, males were more likely to have significant findings outside of the small bowel compared to females. And again, this was statistically significant. We then analyzed the effect of veteran status on our overall findings. We found that veterans were significantly older compared to non-veterans, with a mean age of 67 years. They were more likely to have significant findings on capsule examination and had more angiodysplastic lesions, 33% compared to 15% of the non-veterans. They were also more likely to have significant findings outside of the small intestine. We then looked at the impact of age on the findings and found that it was more likely that patients over the age of 60 had significant findings compared to those younger patients. We subsequently performed an analysis of comorbidities to determine if patients with comorbid conditions might have a greater prevalence of significant capsule findings. Unfortunately, we could only do this analysis on inpatients, and we were limited by a small sample size for all the comorbidities that we examined. We looked at comorbidities including cardiac valvular disease, coronary artery disease, cardiomyopathy, pulmonary disease, end-stage renal disease, and cirrhosis. We did not find any significant differences between those patients who had significant findings and those who had normal or insignificant findings on capsule endoscopy and those who had comorbid conditions. But again, the number of patients in each cohort was rather small. It was interesting that we found that patients, particularly males, had more significant findings outside the small bowel. The most common finding was erosive esophagitis in male inpatients, occurring in 7 patients. We also found other findings, including portal hypertensive gastropathy, peptic ulcer disease, angiodysplasia in the upper and lower tracts, blood in the lumen, and 1 patient with colorectal cancer. We also found 3 patients with gastric antral-vascular ectasia syndrome. These findings agree with the prior literature that has demonstrated that in cohorts of patients with obscure bleeding, approximately 10 to 35% will have lesions found in the upper or lower tract on repeat examination that were missed by the initial examination. In summary, our study is novel, demonstrating that patients who underwent capsule endoscopy as inpatients were more likely to have significant findings. In addition, the inpatient studies were more common in men. Angiodysplastic lesions in small bowel were more commonly found in males, regardless of whether they were inpatients or outpatients at the time of capsule examination. And we also found that male patients were more likely to have significant findings outside the small bowel on capsule endoscopy examination, emphasizing the importance for the capsule reader to examine the esophagus, stomach, and possible duodenum in addition to the colon when reading the capsule endoscopy examination. Thank you for your attention.